great to be up on stage with you guys. This is fun. My name is Pam Ressler, and I have the pleasure of moderating this panel this afternoon. We hope that we're going to engage you guys with a lot of good discussion. But let me just start by framing what our panel is going to be about. Let me start with a quote. In your home, you're safe, you're free. Home means happiness, quietness, protection. If you've been away and walk into your home, there's a feeling there, especially if you come from a hospital. When you step in that door, I can't explain it. Maybe it's like going to heaven someday. These are the words of a patient being cared for in his home. So let's pose a question. What if the hospital wasn't where you went when you were ill? How might we reimagine the site and delivery of health care and relegate hospitals to the tertiary role in care? I'm Pam Ressler. I'm a nurse, and I'm the founder of Stress Resources, a firm committed to building resilience in individuals and organizations. I'm also an assistant clinical professor at Tufts University School of Medicine in pain research, education, and policy. And I'm thrilled to be moderating this panel today with these three amazing thought leaders at my side. Our panelists will inspire us to think outside the box of traditional home care, discard the notion that simply more technology is the answer, and challenge us to imagine a seamless healthcare delivery system of the right care at the right time in the right environment when you want it. Elegant and easy. Think of it as Amazon Prime for your health. So let me introduce the panelists. The farthest end of the couch is Rakowski. He's the CEO of Medically Home, a disruptive technology-enabled health services company dedicated to quantum improvements in patient care delivery. Next, sitting next to Richie is Marianne O'Connor, who's the president and CEO of VNA Care. She's a nurse leader with over 3 decades, 29, of direct care and management experience, who sees an opportunity available for healthcare transformation with this model. And to my right is Dr. Pippa Shulman, who is a primary care physician and geriatrician at Atrius Health. She's also a part-time clinical instructor at Harvard Medical School and the chief physician of Medically Home. Over the 10 years of clinical practice, Pippa has come to understand that you can never really know your patients until you see them at home. So with that, what we'd like to do is chat a little bit up on stage. We'll be showing a short video and then throwing out some questions and dialogue to the audience. So let me start with you, Richie, if that's okay. What's your vision of for a reinvented healthcare system? Seems like a tall order, huh?
Yeah, so I had a personal experience with my dad in a hospital that kind of started my journey, lost him to 3 medical errors. And I'm an engineer by training, so about 7 years ago, started with the idea of what if we reimagined what an episode of medical care would look like if the patient was the only thing that mattered. So we began with the idea that the silos of care, beginning in the hospital, then transitioning to other care and post-acute world, and then back in the hospital, that all of that wasn't what we needed to focus on. Instead, how do we reinvent the actual care episode? And we ended up with an idea of 30 days. Starting with a 30-day episode of care. And when we did the economics on a 30-day episode of care, needless to say, at $1,500 a day in the hospital, we couldn't sustain that. So we developed the idea, what if we moved the patient home? So tethering the home to a safe and high-tech connectivity mode with a medical command center was where we began. And what we imagined was care being delivered to the patient and to their home when they needed it, no transitions of care, a single care team, and all the services that the patient needed during the acute phase of care and all the care they needed post-acute would be delivered in the home by a single team. That was the idea. And together, a group of very, very bright and passionate clinicians, engineers worked on this for many years, and now we are live in Boston treating patients. So that's the backstory. In terms of the reimagining of care, if you follow where the care is paid for, that's going to take you to the institutions of care, hospitals, skilled nursing facilities. If you follow what the patient needs a lot more care over a longer period of time. They need to be home. They need to recover in the safety of their home, and more important than anything, during the course of our care with our patients, and Marianne will talk about this, we develop a relationship with both the patient and their family, and we discover what actually caused them to be in an acute situation to begin with, and that's the real magic of what we do, is building that relationship at home with the patient and their family. So more care, longer period of time, and brought to you exactly when you want it and when you need it.
Sounds pretty perfect. But we'll talk more about how this really happens in this reimagining of care. So let me ask you, Pippa, as a clinician in this model, what benefits does this kind of home care have for the patients, and maybe also speak a little bit to the benefits for the providers?
So looking back, 15 years ago on July 1st, I walked into a hospital, and I didn't leave for a year, basically my intern year, overnights, long hours, admitting what felt like the same patients over and over again, and feeling like, what have I done? Really seeing the opportunity of the system, but also how the healthcare system was broken. And on July 1st of my second year, my first rotation was with our frail elder home program at my residency, which is actually amazing to think about that we had one. And instead of going into the hospital, I walked into a patient's house, which I hadn't ever done. And it was a revelation. I knew this patient. I had taken care of this patient in the hospital many times. And all of a sudden, I realized exactly why the patient kept coming back to the hospital. When I asked to see, can you show me how you organize your medicine? Oh, it was a great system. All the pills were kind of just on the counter. Some were poured into a pill planner, not always the same pills. And can I see what you had for lunch today? I see an empty plate there. And all of a sudden realizing all these pieces that I had never known about. Maybe I'd asked, maybe I hadn't asked. I'll be honest, probably I hadn't asked those questions. And so there's this opportunity where all of a sudden I have a window into what's actually happening for the patient. For patients, we know that patients who go to the hospital are asked to lie in a bed and only get up when they're told to or when they're with somebody, and so they lose functional status incredibly quickly. It's an unfamiliar environment, and so often people experience delirium and confusion. We alter the day in the hospital, so it makes no sense to you, but yeah, we're going to wake you up when we feel like waking you up. I know there's been some great talks this year around how can we redesign those settings, but what I really wanted was, can we avoid those? And there are many models of hospital care in the home that have proven that you have lower rates of falls, lower rates of confusion, obviously less complications like hospital-acquired infections, because you're not getting hospital-acquired infections. And so I really became intrigued with how can we do this as soon as possible. Now, for the clinician, this is exactly why I went into medicine. It's to be with people, to come face to face again with that relationship. There are lots of cool gizmos and gadgets and tech and amazing things we can do, but ask most, I hope, doctors why they do this. It's because of the conversation they have. And when you go into a patient's home, you are vulnerable to them, and often they will open up to you. We just admitted our first patient to our hospital at home program in May. And it's an amazing story that I want to share part of it with you today. The patient had had 6 previous hospital admissions in the first 5 months of the year, all for acute exacerbation of chronic disease like congestive heart failure. He was 93, but very independent, still mowed his own lawn, did his own cooking, shopping, taking care of his companion. She noticed he wasn't feeling well when he didn't make her coffee one morning and was confused because he couldn't remember how. And we said to him, we can admit you to the hospital, you're really sick, or we can set up a hospital in your home. And he said, well, I don't want to go back to the hospital again, so let's try this other thing. The rest of it hasn't worked very well. And so we entered into Chuck's house, and it was amazing. And it was amazing for Chuck, but I think it was more amazing for me and more amazing for members of the team to see what we could do. We went back to see Chuck last week, and we got permission to have a conversation to film with and share with you. So I do want to share a quick video, and then I'll give you sort of the follow-up to Chuck. So let's watch the video.
So if you had a choice to go to the hospital again or to stay home with Medically Home, what would you tell other people to do? Would you tell them pick the hospital?
I'd tell them forget the hospital.
You'd tell them forget the hospital?
Yeah.
Why wouldn't you want them to go to the hospital?
Because they get better care at home.
Medically Home is the idea that a patient who is sick at home, instead of having to go in the hospital and be in an unfamiliar, scary environment, can actually receive excellent hospital care in their homes. Chuck's story, it's amazing that he was our first patient. Dan called me and said, I've got this guy in the office, and he's been hospitalized a bunch of times this year already, and I don't want to send him back.
When he had been in the hospital, we thought that would be our saving grace, but it was just a block everywhere we went. You try to help advocate for someone that's legally blind, hard of hearing, in his 90s, that won't fight for himself anymore, and you kind of hit a brick wall, and they send you home. We always said that there was angels surrounding this program. We could press a button and say, he looks a little off right now, and you'd get the nurse, you would get the doctor.
We were able to reconnect him with his family, his daughter and granddaughter, and the rest of his family, and that was amazing.
They were able to see a little bit more of what our family had seen. I'm sorry, I'm getting a little emotional.
Yeah.
He's a yes and a knower.
Yes.
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 Um,
Yes.
Medically Home, to me, is just the beginning. We've shown that we can successfully admit patients to a hospital in their living rooms.
But we still can't stop crying.
I know,
We're
so
trying.
that's what, it's like, oh my God, that miracle happened.
Very cool.
Yeah, it's really cool.
Very cool.
I want to give you a little bit of backstory, and again, I have permission to share some of this. The first night we admitted Chuck, he didn't look like that. He was pale, didn't have the handsome mustache, laying in his recliner, and a little bit short of breath. And I said hello, and immediately there's an iPad that he has, and there's a nurse in the home with him. His significant other grabbed the iPad and started talking, and I realized that I may or may not be able to help Chuck medically, but his significant other's anxiety disorder and what it was doing to his home life was really what we had to figure out. And what we came to understand is that, in fact, Chuck had been estranged from the two women that you saw on screen with him today, his daughter and his granddaughter, and the rest of his family. And there were lots of reasons behind that. And he had felt, as he got older, and he's, you can see, sort of a taciturn guy, he felt that he really had no choice. And we had an opportunity to have a meeting with him and his primary care physician and other members of our team, and ask him, where do you want to live, and who do you want to live with, and how do you want to spend the rest of your life? And he said, and he told us he did not want to go home and be in the environment that he was in, and that he never wanted to go to the hospital, and that he wanted to be able to, tinker and do some other things. And so we were able to make that possible. And that's not what you would think of as hospital care or medical care, but that's what we do. We don't just do the acute period. We stay there with Chuck for 45 days. We were in his house. And that level of trust, this is a different kind of healthcare. And we really feel that there's an opportunity to deliver this to everybody.
And with that, our notion of what home care has been, you've kind of turned it on the head. And home care has also been a place where nursing has been very prominent. And so I'll throw it over to Marianne as a nurse and myself as a nurse and ask you, Marianne, what would surprise us about the current state of home care that makes this new model that we've just witnessed possible?
Well, first, I think I would like to say that healthcare is moving home, and home care and hospice has been moving right along with it. But before I get into talking to you about all the different new technologies and what nursing is doing in the home that is so much different than when I first started many, many years ago, I would like to just emphasize the whole point of what Pippa was talking about, the social determinants of care. I mean, one of the first things that one of my best nursing professors ever taught me was that the source of all illness is loneliness, lack of hope, things like that. So when you go into the home, that's what you see first. So, and you know that and the thing I love about Richie's model, the medically home model, is that you've got time to get to that. Before, the hospital is maybe 3 days, you have very difficult transitions where home care is trying to really rapidly pick up and get things on track. Then you may have 60 days, but you may not have enough time in that home consistently. So before I launch into all the new and trendy things that we're doing that are making a huge amount of difference, I would say that really what a home care nurse is really trying to do is to get at what is going underneath it all. And that's why home care nurses stay in home care, because of that work. But let me just tell you that it may surprise you that one of our number one priorities is sepsis, because we now know through our data that most of our patients go back, and when you figure out what's really going on, it's underlying sepsis. It may surprise you that we can do home infusion. I still, in this day and age, have doctors say to me, "Are you kidding me? Can you really do home antibiotics?" Yes, we can. Home antibiotics, hydration, biologics, all those different things are going on in the home. It also may surprise you that we have a full-blown telemonitoring service right on site, so that 365 days a year we can monitor our patients and pick up alerts quickly, because our job is to keep people out of the home as best we can from going into the emergency rooms and going into the hospitals. It also may surprise you that we have a community palliative care program, so patients with really tough symptoms that are hard to deal with, our nurse practitioners certified in palliation go into the homes. We also have an advanced scribing system right now. Nurses, I think, do definitely get hooked by what's going on in the home and the intimacy and the fact that they can really sit and talk to people and try to figure out what's going on. But one of the worst things about home care was the tremendous burden of paperwork. So we think we now have a solution to that, so that nurses are connected back to the office with a scribe, and when they walk out of the house, they're done. An admission to home care, believe it or not, it can be 2 to 3 hours. We've got it all done in 55. And the nurse does not take in her laptop, and it's all patient-facing the entire time. So we're really very happy about that. And we feel like the relationship with the physicians is a real one at this point. It isn't, we're not sending reams of paperwork to physicians and they're signing it and we have no contact. I remember when I first met Pippa, trying to tell her that I know we could do better if we could get to the doctor quickly. So we have a care in place program. If we get a call for our care in place program, we can deploy a nurse within 2 hours. Within 2 hours, a nurse is there. They walk into the home, they're connected through technology back to the doctor, and they do the assessment together, and we have prevented hundreds of emergency room visits and hospitalizations, because many things can be taken care of right there in the home if you've got access to the doctor. So we have fixed that. We are also being approached now by the insurers. Home care is being approached by the insurers to take care of their sickest patients, because our strategy now is not a post-acute strategy, it's a pre-acute strategy. So we've designed many of these programs so that we can catch this before. Much like what's going on in diagnostic, catch it much earlier. So we're trying to get upstream from all of this and really keep people out of the homes. And we have many nurses now, and nurse practitioners and physicians are really happy to be working with us in the home care and hospice environment.
I'd love to, you've heard a bit from each of our panelists. You've heard a bit about what's happening right now in home care. This isn't your great-grandmother's home care, it sounds like. And so we'd love to open it to some questions from the audience about how does this really work? What's it all about? So we do have a mic here, so I'm going to ask for you to raise your hand. We have a lady right up here. And direct your question to any of the panelists, please.
Okay, I think this is probably for the doctor and the nurse. So my question is this: when you go into the home, you referenced the fact of, in that particular gentleman's case, the anxiety disorder of his partner. The kind of issues that you run into are going to be quite different depending on the family dynamics. How are you equipped to deal with that?
That's a great question. So, because we don't know what you're going to walk into, and that's true if the patient's walking into my office or in the hospital room or into their home. A couple of things I'll say. One is that the home care partner that we've chosen has a very robust behavioral health program themselves. They've been providing behavioral health in the home for some time. I know we're interested in some of the new technology options that could help us with that. We also want to make sure that we're linked up with community organizations that can help provide support. So in Chuck's case, we connected with actually her treating team and tried to align the services that she needed, get them engaged, explain what was going on, because just as Chuck is my focus and all of a sudden I'm seeing all the things that are factoring into his health, her treating team has no idea that her significant other has just been hospitalized in her living room. So there's all sides. You start to unpeel the onion. Each side needs to know that, and so engaging them early was really important. And we can do that in a lot of different ways. We have the ability to use virtual consulting services. So whether for specialty medical care or behavioral health care, we can do that virtually. Care in the home is going to have to be a hybrid, high-touch, high-tech model. There's no way you can scale anything well by just continuing to send a person every single time. But we find that if you are able to really act as a team, that the patient feels known by every member of the team, whether they're on a video, a phone, in person, that builds trust, that the patient knows when I need help, I can reach out, and we're going to provide a solution or an attempt at a solution.
Hi. Yeah, what's the financial model for this? Like the reimbursement, how does the money all work? And then the second question is this available nationwide, or is this a very regional program at this point?
Let me address that. So first, the second question, we're in Boston today, expanding to Indiana probably in the first part of next year, and have ambitions to grow the model across the country, but beginning now in Boston. The financial model is an average medical diagnosis in the hospital today is between $10,000 and $15,000 of reimbursement, of which about 60% is fixed costs, bricks and mortar, not care. So the average patient that we tend to address has about 20 to 30% of them have post-acute care costs, which the payer pays for as well, and then a very, very significant amount of readmission. So through the lens of the payer, the expense of a typical patient is anywhere from $15,000 to $25,000. The financial model is a bundled single payment for that patient over a fixed period of time, a minimum of 30 days up to 90 days. So from the financial model point of view, the payer is is getting a very significant reduction in costs for the patient's point of view, an extended period of care in their own home, and from the provider's point of view, an opportunity to have a very deep and extensive relationship with no transitions over that period of time. So payers get savings, patients get better care, providers get a deeper and more profound relationship with their patients and the families.
I also want to add too, I think we want to stimulate a conversation around how innovation in the home can happen in general. I think when often at MedX we're hearing about innovative hospital, innovative in the clinic, new ways to virtually deliver care. We actually really reimagine the home as the site of care, or maybe some other place, but that we aren't tethered to these buildings and facilities, no matter how beautifully they might be built across the way.
Yeah.
Hi, Mary Ann mentioned briefly about home monitoring systems and privacy issue, and I will call the dignity issue. So we know most incidents might happen in the bathrooms. How do you handle those kind of dignity issue? People wants to be monitored, but doesn't want to be monitored in certain areas.
Are you talking about the video monitoring of the patient or the vitals monitoring the patient?
So currently, the video monitoring is on demand from the patient, and so they initiate it, or we have a set time that we call them. There are actually some excellent technology out there that allow us to discreetly monitor what's happening in other areas of the house, such as the bathroom or the bedroom, but without compromising the patient's privacy. So there's lots of companies out there that are using heat signals or sound. There are wearables, obviously that can detect falls. So there's lots of ways to attack this. We really, it's a great question, and I think we really believe that the patient should be able to initiate our seeing them. And I think that's why a lot of these home care, sensor monitoring, et cetera, fail, because you have a very well-meaning child of an older patient or a frail patient who wants to monitor everything, and that is not what people want. That is not autonomy and dignity.
Right. And the telemonitoring I'm talking about is really all about their biometrics. It's their weight, it's their blood pressure, it's their pulse, and all of that. And so when those are outside of parameters, there's an alert, and then we can catch things early. And yes, there are many of those systems out there, but that isn't the one I was speaking about.
Super great. We're all paddling in the same direction, working more towards the end of life and a palliative care model, but completely doing the same thing with the same point of view, the same perspective, the same person-centeredness. I want to know how hard it's been to get professionals to get comfortable and to move in that area, and then how their experience has been in adopting the video conferencing window as the channel for communication.
Michael, is there one specific professional group that you're interested in, or just in general?
Well, I mean, doctors are
very
much
That's
of
fair.
a pain in the ass in most change-related topics. But actually, our chaplain has finally flipped in our practice to become so enthusiastic about using the technology. Nurses are a little bit slower. The social workers just can't quite give up getting all up into the dirt of the home to figure out what needs to be done. So it's different in our practice. It's been an evolution, and I've kind of let all those individuals kind of find their own way and pace without pushing them too hard. But I'll tip my hand that it's better than real life. Mm-hmm. So I want to hear, though, about the experience in your organization, about how adoption and the resistance that precedes the adoption shows up.
So so it's a great question around adoption, because I think there's certainly folks who are initially frozen in fear. They're not our first choices on our hires right now. We'll get to them. Our team right now, two of them had no experience with using any technology except the EHR and the most rudimentary kind of tap, tap, tap system. And so one of the things we had to do was there's practicing, but also setting up the environment so that they could have the thing that they knew to hang on to. And then there was this video, and we did a lot of test runs. Before we admitted our first patient, we tested with, we were using employees' spouses, employees themselves, we're going to employees' houses and practicing what that's like. I think your point that you realize it might be better sometimes is that the video and the technology disappears really quickly. And that when you start the admission, which is kind of the longest visit that we have, it might feel awkward for a minute or two, but then very quickly, because you are looking at the person, you are making eye contact, you can actually see everyone in the room, you can see their house, you can see what's around. And there's someone in the house who's kind of helping, if I need to see the legs or I want to see X, Y, or Z, and it does really disappear. I will say that in our organization, in general, even folks who we thought would be slow to adopt it have been really excited because it allows them to have variety in their practice. So, for instance, our dermatologists now do a lot of telederm because it's something different in their day, and it provides great satisfaction to patients. And they're tired of hearing patients say how long they have to wait for dermatologists.
So, Pippa, if I may, the other, I think, unique quality that maybe address part of your question is the model is bidirectional. Yeah. So the patients who are particularly the type of patients we interact with, they're used to waiting a long time to get access to a clinician. The fact that they push a button, and when the woman said this is a miracle, what she was responding to was that every time she pushed the button, there we were. And the level of surprise and shock the patient has at the accessibility, the immediacy of the accessibility causes this emotional reaction that then feeds the clinician and has the clinician overcome whatever resistance. And that's the dynamic which I think you're referring to. Mm-hmm. The patient's access, this dramatic shift in access, creates literally a mood shift between the patient and the clinician, and that's enabled by this technology.
I think the other thing that's really important to realize, though, that the Atrius Health model, Atrius Health partners with a 1,200 employee home care agency, a hospice, and a palliative care. So with the technology, once, if there's a need for somebody to go in the home, a nurse practitioner will show up, an RN will show up, a physical therapist, a speech therapist, an occupational therapist, a social worker. So there's all of this technology to connect quickly to make sure that you're on top of what's going on with the patient and what they need. And in the first patients that we've done, we have been able to deploy quickly and the right level of practitioner.
I was surprised, though, the first time I did a family meeting really around advanced care planning by video, I was nervous. But the patient was in their familiar environment with their family. And I was actually on the outside rather than them sitting in my environment. And it went so much better. And so it really is magical, that two-way street.
Question in the back? Oh. First over,
sorry.
Hi, my name is Christina Groot, and I work at Karolinska University Hospital in Sweden. And I'm interested in the responsibility, or maybe I didn't understand correctly. The doctor that makes the decision that the patient can be cared for at home, is that person belonging to the same home care unit, or is it two different organizations?
So it's actually one organization, but I think, we have clinical stability criteria and social stability criteria, and so I think they could be differing organizations. There's a referral process and a screening process, just like you would transfer a patient between facilities. We're about to go into a hospital and take patients out of ED, and it's going to work like a transfer. They know the criteria that we need and what we're looking for, so that we can accept the patient. But right now, we're all under the same roof. It's easier to test that way.
Question
Hi,
back.
it's a great concept. I am an orthopedic surgeon who had outpatient joint replacement surgery done on myself, and I recuperated at my surgeon's home. So my surgeon thought, has never seen anyone recuperate at home, so it was a learning experience for him as well. But how do you decide internally as a company which patients qualify for a medical home admission? I mean, clearly you're not admitting an acute MI.
Right.
So how do you internally decide? What's the low-hanging fruit of the kind of diagnoses?
You know, it's funny, low-hanging fruit is the total joint patients. That's where we're going next. So I love it. I want to meet
Thank
your
you for the
surgeon.
question, yeah.
That's fantastic.
I'm going for my second one in 3 weeks.
That's great, because we're doing ambulatory joints as well, and we're talking about, you know, right now the patients who are selected for an ambulatory joint, they're, you know, they're very healthy, and we think we can now take people with some chronic diseases. In general, though, when we're looking at patients with non-surgical issues, so medical issues, you're right, we're not providing ICU level care in the home. Maybe someday we will. If you need, you know, advanced diagnostics, a surgical procedure, or you are a mystery and we don't know what's going on, and your goal is that you want to find out and be in a hospital, then probably a hospital is a good place for you. But if this is an acute exacerbation of chronic disease, you've had your workup, we know what's going on, 80+% of what you need is treatment, and or your goals of care are to stay out of a hospital, we can very effectively treat you at home. And we have protocols for each diagnosis that we treat, and we started slowly. So we've really started with, I think you could probably predict what our first 13 diagnoses are. It's, mostly acute exacerbation of chronic disease. We pick those, and we do have clinical care protocols for each member of the team to make sure that we're providing really safe care.
So if you look at all the diagnoses that a hospital admits for, roughly 80 of the 250 qualify for the program in terms of safety. In terms of payer class, commercial payers now, MA now, fee-for-service Medicare coming soon. So roughly 30% of all hospital admissions patients today would qualify for the program, and that includes excluding those patients that are not clinically or socially stable enough to go home. But thank you for bringing up the question about the joints, because that's next.
Another question. I think we have time for one or two more questions, if anybody has them. And if not, I will ask the panelists myself a couple of final questions. So I'm fascinated by this. I've been in the healthcare field for well over 3 decades, and certainly my model of home care that I think about is not what you've been talking about. And I find this really exciting and a new frontier. I love that model of how we all think of Amazon. I keep coming back to that Amazon model. I mean, we didn't have that 10 years ago. And so in this reimagining of bringing us into actually so patient and family-centered that the care can be delivered when they need it, that they are in charge of when that care comes, I think is revolutionary. But what I'd like to just go through with our 3 panelists is, I'm sure all of you are thinking about one thing you may take away from hearing about this model, but I'd like to ask each of them, what do they want you to take away from this model? I don't know if they're going to be aligned or not, but let me start with you, Richie. What's one thing that you hope this audience will take with them?
So I was debating what the one thing would be, so I'm going to say it's one thing, but it's going to have an A and a B underneath it, so it'll be a hybrid one thing. So I guess the first takeaway I'd love people to have is the fact that people really want care now when they want it, and we've been so accustomed to waiting in the doctor's office, waiting for the nurse to answer our buzzer in the hospital. We've been so accustomed to delay the gratification of having our care needs being attended to on demand. So I guess the first takeaway is this thing was designed from the outset to be, I want it now, all right, we're going to give it to you now. The second, and I know I'm not allowed 2, but...
You're allowed 2. Everyone can have 2 if they really want, since I'm giving it to you.
I was with someone last night who's got a background in entertainment, and I explained to her what we're doing, and she said, oh, it's 3 for 30. And I said, excuse me? She said, just remember that you're taking 3 days in the hospital and you're changing it to 30 days at home. So that's what I'm going to take away, 3 for 30. So instead of 3 days in the hospital, followed by a lot of disaggregated care, and a lot of transitions, both hard and soft, I'd like you to remember 30 days at home versus 3 days in the hospital.
Good. And going in to Mary Ann, I think that, one of the things that we brought out in the beginning is that home care has been traditionally the home base for many nurses. Nursing functions well in the home, but we've never really had this seamless way of connection. Nurses have been going into homes forever. And so there's an increased level of expertise among nurses, but now you're kind of bringing it together. So I'll ask you, what do you think you want the folks to really remember from this, not your great-grandmother's home care model, Mary Ann?
Well, I think I would emphasize the fact that it's absolutely true that we have absolutely moved into technology, infusion, hospice, palliation, all of that, which is absolutely excellent. But the thing I love about this model is that you have 30 days to figure out what's driving the illness. I mean, we all have family members who have had either heart attacks or something very severe, but you in your heart know that there's something that's driving that illness, that's bothering, and you've got time to figure it out, and you figured it out for Chuck, which was just so thrilling. So I would leave you with the importance of the social determinants of care, and that's where the healing is. And then the last thing is that healthcare is moving home. Whether we know it or we don't know it, it's on the move, and we're trying to catch it. We're trying to stay up with it. And the clinicians that I work with every day are just thrilled about this work because they've been going into homes a long time where they made a difference, and made a big difference, but they knew there was more to do, and now we have more time to do it.
Great. And I think also, what I'm hearing is there's a beautiful synergy of interdisciplinary care is what you are really putting forth. And for those of you in the audience who don't know the difference between the philosophical differences between how nurses are trained and physicians are trained, nurses are trained in a model of wellness and of function, not necessarily of illness and diagnosis. I mean, there's a lot of crossing now with nurse practitioners, et cetera. But what a beautiful marriage of the high levels of skills, using them to the full extent of their licensure in a model such as this. Yeah. So Pippa, what's your closing thought? What would you like folks? And you can have two since Richie took two.
I do want to echo about care moving into the home. You'll see it everywhere. There's home-based primary care, urgent care, post-acute care, hospital care, hospice and palliative care. This is where the innovation is. What I really think about is that what we need now is, and I don't like war metaphors, I'm trying to come up with another word, but a real group of tech-enabled clinical humanists. This is a different kind of clinical provider at all levels. And certainly I know the doctoring side, but this is a new kind of doctor and a new kind of home care nurse and on through. And we're trying to build that. I know there's others out there, and when you are really able to get that group together and practice in a team and know that patient, this is the best. I love my job.
That's a pretty good closing statement, I would say. We talk about the burnout. What a wonderful way to feel energized about this work of healing that we're all here to do at Medics. I mean, we've all come to learn new ways and to hear about these ways that instead of being burnt out, you feel energized and you love your job. That's very cool. And my work around resilience is I gotta, drink some of the Kool-Aid here.
The sparkly toys are good, but it's the human connection. And we've heard this from this stage all weekend.
So just in closing, let me kind of wrap this up with some of those words we heard from the patient when I opened this session. So home is happiness, protection, quietness, and home helps us regain our place in the world. An environment of healing that can be both high touch and high tech, not mutually exclusive. So we on this panel are going to leave you with a challenge. In the words of medics, an HMW statement, a how might we statement, question, how might we imagine a healthcare delivery system as easy to use as Amazon Prime that meets the patient where they want to be, home. Thank you all. Thank you, my panelists. Thank you to the audience.